Hi, I'm Kevin Wilk, and I'm here with Dr. Mike Ryan from the Hip Center at Andrews Sports Medicine.
Yep.
Dr. Ryan, thanks so much for joining us. You're going to go through a hip examination. We're going to do an abbreviated one, obviously, just in a few minutes, so it's all yours.
Yeah, so in general, what I'll typically start with is actually a gait. Watch the patient walk back and forth, make sure there's no abnormalities. This patient obviously has a normal gait. I'll kind of move forward. I think one of the more important parts to the hip examination is really getting a good understanding of the comprehensive range of motion. So flexion, internal rotation, external rotation, both in flexion but also with the patient prone, putting the patient's hip in extension. So we'd start, I'll generally do what's called a log roll test where I gently rotate the hip back and forth. That's kind of a general assessment of any sort of obvious pain. And then also do what's called a dial test, where you let the patient's leg relax. When your leg excessively rotates the outside, or if you push it and it doesn't spring back, that will indicate there's some laxity of the front or anterior capsule. He doesn't really have that. Next, I'll have the patient flex their hip and knee up, and we'll just go into straight flexion. And I'll flex up until I can feel somewhat of an end point, which is generally when the proximal femur interacts with the acetabulum. Most patients get at least to 90, if not a little bit above. If they have some pain in straight flexion, sometimes that could be concern for subspine impingement. Generally, most patients don't have too much pain going forward. So I'll check that's about 90. Then I'll externally rotate with a hip at 90 degrees. Most patients get to about 30 to 45 degrees is about the normal range. Some can be a little bit excessive, some less. And then I think what's most important with this range of motion exam and profile is internal rotation. If patients have limited internal rotation, meaning about less than 10 or 15 degrees, that can indicate some hip impingement. Generally in males, it's a cam, maybe combined in other patients, but that's something you definitely want to look at. And, this patient's got actually a little bit of limited internal rotation. Some patients, if they have excessive range of motion where their internal rotation goes beyond about 45 degrees, you want to think about other sort of potential options of hypermobility, either hip dysplasia or excessive femoral anaversion. The other tests that I will do as far as looking at impingement, one is the anterior impingement test or the fader, flexion, adduction, internal rotation, where you bring the patient up into flexion, you adduct their hip or bring it across their midline, and you internally rotate. Now, I think that that's a decent way to do that. I think a better way is when you think about the acetabulum, it's an arc or a hemisphere. And so what I'll do is I'll kind of ride that entire arc from top to bottom, and that gives a little bit better sort of interaction between the femoral head and anterior acetabulum or labrum, as opposed to just one position that will kind of go throughout that whole arc where labrum tears tend to be.
Are you looking mainly for pain, or are you feeling anything as well?
I think pain is important, but I also ask the patient if that maneuver reproduces the pain they feel, because you can also have other things that become painful, whether it's the capsule, your hip flexors, such as your psoas or your rectus. And so if that is not the reproducible sort of maneuver that causes the pain they feel, then I'm not convinced that that's necessarily a positive anterior pain. Additionally, if you flex them up and perform that anterior impingement sign, but their pain is more lateral, that's not really a positive test, because it's not really eliciting pain from the groin, which is what this test is looking at. Additionally, I'll look at impingement elsewhere, so you can get a kind of a lateral impingement where you abduct the leg a little bit and hyperflex and kind of internally, externally rotate, and then posterior impingement where you let the leg abduct, externally rotate, and you're actually rotating externally to see if there's any sort of impingement posteriorly, which either can be a posterior labral tear, which is very uncommon, but more commonly you can cause levering out the front, which can cause provocation or irritation of the labrum in the front. Additionally, in some patients who are hypermobile, you can do what's called an O'Donnell test, which is a test of the ligamentum teres, where you're kind of in about 45 degrees of flexion, about 20 to 30 degrees of abduction, and you're going to max external and max internal. And what you're doing is you're really eliminating any sort of bony impingement, but you're really kind of putting the hip at extremes of internal and external rotation, really putting a little bit of stress on the ligamentum teres. And that test has some validity to any sort of ligamentum teres partial or full tears as well.
What are you looking for with that? The amount of motion, end feel,
yeah,
pain?
End feel really in pain at the end ranges of motion. So if patients have pain in those ranges, that can indicate a possible ligamentum teres tear.
Gotcha.
Which you'd want to correlate on the MRI and any sort of scope photos. Additionally, I'll have the patients rotate on their side. And so this is a good examination of the lateral or outside aspect of the hip. I'll palpate over the greater trochanter and gluteus medius or abductor muscles. You can feel pain over the tensor fascia lata, a little bit more anteriorly, and then also palpate on the short external rotator, so your piriformis and your other short external rotators just a little bit below that. To test abduction strength, I'll do a couple different exercises. So I'll have the patient with the leg straight, lift up towards the ceiling and resist against my hand. To remove the IT band, I'll have them bend their knee to make sure that they're not compensating, make sure strength is good. And then if I have concern that there's a gluteus medius tear, then I'll also have them extend their leg, internally rotate the foot, which puts the gluteus medius on a good amount of stretch, and have them push up as well to isolate that gluteus medius. Any sort of concern for piriformis, we'll do some special tests there. That's a little bit more specific. And the last thing I'll do is have them lay on their stomach. And again, we'll check the opposite side just for review. I like to check internal external rotation with the patient prone, which puts the hip in extension. This gives you a little bit better understanding of the comprehensive rotation. So have the patient bend up their knee and just have your heel lay out to the side, fall out to the side. And what you can see here is the internal rotation is probably a little bit better in extension than it is in flexion. Here he's got it probably close to 20, 25 degrees, where he's got about 15 with flexion. And then I'll have him externally rotate to check where that is. And you can feel an endpoint. I'll usually keep my finger on the greater trochanter to feel when that end range hits. And again, he's probably about 30 to 35 degrees there.
Sweet.
Yep.
Are there anything you do on physical exam to look at femoral anteversion? I know you look at it radiographically, but what about from a physical standpoint?
Yeah, so I think those two tests in terms of your rotational profile. So the things that lead me to believe that there's concern are the internal rotation and flexion, and in particular the internal rotation in extension with the patient prone. So if you have a patient who has excessive femoral anteversion, whereas this patient's rotation stops about 20 degrees, patients with femoral anteversion, their leg will internally rotate to about 70, 80, 90 degrees sometimes, and that's when I have concern for femoral anteversion, which will lead you to get additional three-dimensional imaging studies to assess that rotation.
Sure. What are you looking for on physical exam with somebody with a degenerative hip?
If you want to turn back over on your back, generally what you'll see with a degenerative hip is global decrease in range of motion. And so a really bad arthritic hip, their flexion will not quite even be at 90. They'll get up to maybe 70, 80 degrees, and you'll feel an end range and they'll start to develop pain. And then their internal external rotation also becomes limited.
Would that be mostly groin pain, or where?
Groin pain,
yeah. That's what
pain.
you're looking.
You'll also get some patients who will have some referred pain laterally, and also they'll say their pain goes down the inside of the thigh to the knee. And so some patients with arthritis can say, hey, I have knee pain and hip pain, and it's important to delineate where that's coming from. But I think that when you flex and they only go to about 70, 80 degrees, and their internal rotation is very stiff, that to me is an arthritic hip until otherwise proven by x-rays.
I think we're good.
Yeah.
Yep, great. Thank you so much, Dr. Ryan. That was excellent.
Yeah, my pleasure. Thank you, sir.